Hello, this is Dr. Jim Collins. Thank you so much for taking some time out of your busy day to get some continuing education. This is a very important course, and I would like to send a thank you to our friends and colleagues out there who actually encouraged me to do some research and put this topic together. It is a very practical course. It's end-of-life care issues and Alzheimer's disease. So if you work in a senior care community, provide home health care, or perhaps hospice, you're going to work with a lot of seniors who have some type of neurodegenerative disorder or a dementia-related condition, most likely Alzheimer's disease. You may care for these individuals for quite some time, for many months or years. And then eventually, of course, that individual is going to come to the end of his or her life, and you may be a part of the team that provides end-of-life care. So, or you might provide services to the resident, the senior, the family members. So I hope you enjoy this course and take something good away from it. So let's get started. I want to show you our learning objectives. Number one, I am going to review physical and cognitive issues. And there are many other things to talk about, but I'm going to try to simplify it and at least talk about the physical and the cognitive aspects, problems, and issues at each stage of Alzheimer's disease. Number two, I'm going to list care goals for end-of-life care. And number three, I am going to explain how palliative and hospice care can improve quality of life. And I will differentiate the two because lots of individuals still confuse palliative with hospice, and some believe that they're both the same thing, which they definitely are not. So many experts now agree that advanced dementia due to Alzheimer's disease is to be seen as a terminal illness. That is very important. Alzheimer's has no cure. It is irreversible. It's neurodegenerative. Medications only work for so long if they work at all. Well, you add all of that up, and that pretty much makes Alzheimer's disease a terminal illness, and one that requires palliative care and eventually hospice. Any interventions should take into account symptom management, as well as quality of life, until you need to focus on quality of death. Advanced care planning should be a part of the treatment approach and is important, especially for end-of-life care. Providing end-of-life care is definitely one of the most important aspects of dementia care, and it is probably one of the greatest things that you can provide for seniors who are facing end of life. This type of care attends to all aspects of life, including the body and physical needs, the mind and psychological issues, emotions, as well as the spirit and spiritual issues. During early stages of Alzheimer's disease, the individual will most likely receive aggressive medical treatment, including the use of psychotropic medications, therapy, and antibiotics. And that is quite normal. During the early stages of a dementia, a neurodegenerative disorder, the treatment is going to be more aggressive to hopefully slow down the process a little bit, to minimize the symptoms that the individual may experience, but there will be a turning point when the aggressive interventions become palliative and when the palliative interventions turn to hospice. As the disease progresses, care will become more palliative in nature, and more comfort measures will be implemented into the care plan. And of course, that is the natural course of care and treatment. Now, although it is difficult, if not sometimes impossible, doctors are not magical, they're not mystical beings, they are not oracles that can see into the future. But for the physician to determine how long the individual will live, it's very hard to really pinpoint when someone is going to pass away. But this is something that every healthcare professional should know. The doctor knows it. There are certain signs and symptoms to observe, to be aware of, and to look for, because they do present themselves. There are certain physical, psychological, behavioral, biological signs and symptoms that can be actually measured as well, which may give us clues that the end of life is really imminent. End of life is usually marked by rapid and reversible deterioration on a daily basis. Breathing changes take place. The ability to eat orally diminishes or ceases completely. And if those are happening, weight loss occurs as well as a loss does in mobility and consciousness. The individual also becomes unable to communicate, experiences double incontinence, which means incontinence of both bowel and bladder, develops multiple infections, including pneumonia, and that individual may also suffer from bed sores. Here are some important points to remember. Alzheimer's disease is the most common cause of dementia, and it is also the most common cause of neurodegeneration. You may be aware of other neurodegenerative disorders like Parkinson's disease, Huntington's disease, amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. Multiple sclerosis is also a neurodegenerative disorder. So is HIV. So, when we stack all of those up, Alzheimer's disease is the most common cause of neurodegeneration. It is the major reason as well for nursing home placement. Age remains the number one risk for developing Alzheimer's disease. If you have taken other Alzheimer's or dementia courses on Collins Learning or CEU Academy, you know that I really do stress that quite a bit. I talk about risk factors, some preventable, some unpreventable risk factors. And the number one risk factor is age itself. The older we get, the greater the risk for developing a neurodegenerative disorder. As cognitive abilities diminish, care becomes more challenging. So if you're a direct caregiver, you must know that every advancement or phase or stage of a degenerative disorder is going to make caregiving more intense, more challenging, both physically and emotionally. During the early stages of Alzheimer's disease, the goals of care are to keep the individual safe and comfortable. Okay, those are the early stages. Safe and comfortable. And to treat any co-occurring disorders, which are called comorbidities. And of course, always to enhance the individual's quality of life. But as the disease progresses, it becomes more difficult to communicate and to understand what is needed in terms of care. And that's why caregiving becomes even more challenging. You may eventually have no words being spoken by the individual you're caring for to let you know how he or she feels or what is going on, or their ability to express their needs. It is going to be quite a challenge. So it becomes intensely more difficult to provide care towards the end of the individual's life. Now, let's take a look at learning objective number 1. Here, I want to review physical and cognitive issues at each stage of Alzheimer's disease. As you know, through experience, many changes will take place as the disease progresses physically, emotionally, behaviorally, and cognitively. Profound memory loss will also occur. Verbal communication will deteriorate, and that's going to make it very difficult and very challenging for you to provide care or to understand what the senior wants. Mobility will slow down to an eventual halt. The resident or the senior may become bedbound, immobile, or may need a wheelchair. The individual may be unable to even sit upright by him or herself. Another physical challenge, and something you have to be very, very aware of, are swallowing problems. Because swallowing problems can lead to choking, aspiration pneumonia, hospitalization. I know it just looks like two simple words on your screen, swallowing problems, but believe me, they can lead to horrendous conditions later on. Eating and drinking, some of the things that we enjoy the most in our lives, will become problematic for the senior. Weight loss, poor nutrition, and hydration may also become problems as the disease progresses. The individual may show no interest in food whatsoever, and many times caregivers and family members feel very terrible about that, and they want to give that senior food. They want to give that senior something to drink. And poor blood circulation can lead to other physical problems at this stage. The individual may become incontinent of bladder, bowel, or both. And when both occur, bowel and bladder, it's called double incontinence. The individual may also become more prone to infections like pneumonia. normal facial expressions of happiness, joy, pain, fear, sadness, they may all become lost eventually. And senses will start to diminish. Hearing and sight, smell, touch, they will all slowly disappear. And sleepiness, fatigue, signs of being tired, being unconscious, those things will increase. The individual may start to become more restless and agitated, moving around, displaying the inability to try to find comfort but not finding it. And sometimes the person may become aggressive as well, verbally, yelling or screaming, striking out physically. There are a number of ways that the individual can show signs of aggression. He or she may experience breathing problems, an irregular pulse, skin issues, and definitely pain, which needs to be addressed. But before it can be addressed, it has to be identified. Let's look at general stages of Alzheimer's disease. Now, throughout my entire career, I've seen, read, heard of a number of stages. First, the 3 stages of Alzheimer's, and then there were 5, and then there were 7, and I think I've seen 9. And it gets a little complicated, and most people really just, for practical purposes, categorize the stages of Alzheimer's as mild, moderate, and severe. So let's take a look at each one of these in a little more detail. The mild stage is marked by independent functioning, but with a little bit of memory loss, a little bit of memory lapses. And the individual, for all sakes and purposes, looks and acts quite normal. We all forget things from time to time. We all have lapses in our memory. So the individual, though, at this mild stage, might get lost every now and then, particularly while they're driving. But then we can also say they get lost in their thoughts, in their memories. But getting lost is also a physical complication. Poor judgment may be observed, going out and driving at night when they don't normally do it, climbing the staircase when they've had problems using the stairs. So taking unusual risks might be a part of the mild stage and something to watch for. Increased confusion is definitely a characteristic of the mild stage of Alzheimer's disease, and it starts to build. It's increased, but it's still mild. Problems with complex tasks, things like building something, putting a piece of furniture together, taking something apart, attempting to fix it, putting it back together, that becomes very problematic in the early stage of Alzheimer's disease. Problems expressing thoughts and problems expressing one's feelings are also hallmarks of this stage. For instance, if you were to say to someone, "You seem to be confused," or "You seem rather upset right now, what's going on?" They may have a difficult time expressing what they're thinking. And then we move into the moderate stage, or we could call this the middle stage. The individual now requires more assistance with independent activities of daily living, like balancing a checkbook, using a credit card, paying bills. scheduling appointments, following through on them, cleaning the house, preparing meals, things like that start to get a little more complicated for the individual. And of course, they also require assistance with ADLs, and those are the basic things that you and I do every day to take care of ourselves: bathing and grooming, dressing, toileting, eating. Self-care becomes increasingly more problematic, and generally family members are the first, or close friends are the first to notice that the individual is having a problem with these things. So self-care becomes more and more difficult to perform. Agitation and aggressive behavior may start to occur, and it's quite natural that an individual who is becoming more and more cognitively impaired, cannot find the words, is losing memory, would become frustrated and perhaps physical about it. So other things start to develop as well. Unfounded suspicions or paranoid behavior. An example, and this is a real life example, that I heard many years ago from a friend, is that his father was developing what they thought was some form of dementia, probably Alzheimer's disease. And he was rather sloppy about taking his clothes off before a shower and leaving them anywhere. So a pair of his underwear ended up under the bed somehow. And they apparently were there for a couple days, and he found them himself. And he became suspicious that his wife was having an affair. He swore that the underwear were not his, but belonged to her lover. So there you have it. The individual also begins to forget very recent events, like what did you have for breakfast this morning? What did you have for lunch? Where did you go today? What did you do this evening? So on and so forth. Specific ADLs like dressing, grooming, and bathing in a lot of research articles that I've read. Those three, for some reason, require more help and more assistance than other ADLs. Sleep disruption becomes more profound. We also see not mild, but significant behavior and personality changes taking place in this moderate or middle stage of Alzheimer's. That brings us to the third stage, which is the severe stage. Here, one's physical, mental, emotional, and cognitive status, all of them, continue to decline and deteriorate. There will be a point where communication is completely impossible. Generally, it begins with verbal communication that deteriorates to the point where they can no longer express themselves or understand verbal language. But nonverbal communication, which is very effective, usually, and can be very effective, begins to deteriorate as well. During the final stage, there's usually an increased incidence of various types of infections. The one that comes to my mind right away, urinary tract infections, or UTIs. There is a loss of ability to control movements. The individual may experience double incontinence, which is bladder and bowel incontinence combined. There may be a complete loss of physical abilities like sitting up in a chair or walking. And the individual now has advanced to the point where he or she needs care and supervision 24 hours a day, 7 days a week. Okay, that brings us to learning objective number 2. And what I would like to do here is list care goals for end-of-life care. First, there will be an increased need for care and supervision as the disease progresses, especially during end-of-life care. Needs tend to become far more complex than they were during the early stages of Alzheimer's and even the moderate stages of Alzheimer's. So caregivers have got to be prepared to deal with more and more complicated care needs. The inability of the individual to communicate his or her needs makes caregiving even more challenging. True person-centered care is the only way to approach the person's needs during later stage Alzheimer's disease and especially end-of-life care. Now, let's look at some common care issues that an individual diagnosed with Alzheimer's disease and they are now requiring end-of-life care. There are multiple issues. I'm trying to capture some of the most common ones. For instance, as the immune system deteriorates and resistance declines, you might expect multiple colds, flu-like symptoms, more infections, and something that can be very damaging or deadly, pneumonia. Be prepared to see the older adult or the senior sleeping throughout the day, and then they're up at night. They will experience, as the caregiver will as well, difficulty communicating and understanding language. The individual might develop swallowing problems, which can be mild or moderate, all the way to life-threatening. Choking becomes a problem. Aspiration pneumonia may develop. The individual has great difficulty using the bathroom independently. So if double incontinence is an issue, the caregiver must be very aware of any signs that the resident is offering, verbal, nonverbal, whatever it might be, that he or she needs to get to the bathroom and soon. Help and assistance with activities of daily living, or ADLs, will only increase as the disease progresses towards the end of life. And ultimately, the individual will be unable to walk on his or her own. Okay, this is the part of the program where I like to thank you for your time and for your attention. And this is a pretty important topic. I hope you're picking up something, perhaps that you didn't know or you haven't thought about for a while. But taking care of individuals towards and at the end of their life, especially those with a neurodegenerative disorder like Alzheimer's, is a very admirable thing. So thank you for doing what you do for seniors and improving their quality of life, helping to manage their symptoms. I think it's a great thing that you're doing. And I also thank you for taking some time to get some good continuing education. I hope it's good continuing education for you. So let's take a look at some more common care issues. There will eventually be a need for walking devices, perhaps a walker or a wheelchair, and eventually the individual may be completely bedbound. You may see some hoarding behaviors taking place. Perhaps the individual with Alzheimer's is rummaging through their belongings or getting into another resident's room and rummaging through theirs. So wandering might become an issue, and you really do have to figure out what's going on with wandering. A lot of it is purposeful. They're trying to find a familiar place. Some of it is due to anxiety and confusion. And sometimes they're just wandering looking for water because they're thirsty, or a bathroom because they have to go to the bathroom. So wandering's not necessarily a bad thing. It can be a form of activity, and it should be supervised as well. Now, the bad end, or the bad outcome, I should say, of wandering is elopement, and that's far too risky. That's when an individual who started by wandering gets out of the building and goes down the street or into the parking lot or into the woods or whatever the case is. So we have to make sure that that doesn't happen. Another common care issue is the inability to eat independently. Perhaps incontinence becomes an issue. The individual, unfortunately, will lose awareness of their surroundings, and you will see increased confusion, sometimes personality changes, and you may also see lots of behavioral changes taking place. Social withdrawal might be an issue. Sundowning, which is a fascinating topic. I'm going to take a break and tell you all about sundowning in a course, brand new course, that I have written, and it's called Sundowning an Overview. And it's an hour long, so if you're interested in sundowning, I have the latest information based on research and studies, what it is, why it happens, what to do, so on and so forth. So check that course out if you're interested. But other care issues include verbal or physical aggression and demanding behavior. So a seasoned, experienced caregiver or healthcare professional, they know that these are a part of the clinical picture. They have experience effectively dealing with them. But if you're newer to caregiving, I don't want you to be frightened by, wandering and elopement and increased confusion and aggression, so on and so forth. Just learn about them, take a person-centered approach to the older adult you're working with, get to know who they are and what they do. Now, here is a special note on wandering. First of all, it's going to happen most likely. Statistically, 3 out of 5 people with Alzheimer's disease are going to wander. That's all there is to it. It involves confusion and disorientation. Wandering, like I just said a few moments ago, can be healthy, or it can cause a lot of safety risks. Here are some reasons why a confused and or disoriented resident would wander. They've got a full bladder and they need to find a bathroom, or they're constipated and they feel pressure in their gut and their GI tract, and that pressure makes their body move. It's just a natural phenomenon. Perhaps they're tired, they're fatigued, and they're fighting it. They have an infection, and the infection is causing burning sensations, tingling sensations, or various types of pain. And that will make someone get up and walk. Perhaps the reason for wandering is fear, or the resident, the older adult, can be very frustrated and they just have to get up and move. Perhaps they're hungry, so they'll look for food. They might be thirsty, so they start looking for something to drink. They can misperceive that their life or their well-being is being threatened. It could be by another resident, perhaps a staff member, a visitor, a family member, perhaps no one at all. That's why it's misperceived. This could actually involve hallucinations and delusions. Skin irritation is a common cause for wandering, as is untreated pain. And pain is a big, big deal. When you have a senior with advanced Alzheimer's who cannot communicate pain, then the professional caregiver has got to become a detective. They have to practice person-centered care, and they have to figure out where the pain's coming from, what's causing the pain, and put together a treatment program for the pain. Here are some care goals as the disease progresses. Care goals are simply going to change. Everything is going to change. Open and ongoing communication is critical between caregivers, healthcare professionals, the resident, him or herself, family members, and anyone else involved in care. The resident should be a part of the decision-making process up to that point. And sometimes we don't know where that point is, but until he or she is no longer able to be a part of their own decision-making process. And at that point, the family or the surrogate decision-maker, perhaps a legal guardian, family member, or friend, becomes a greater voice. And care professionals rely on those surrogates and family members to help in making good decisions for the older adult. The goals of care should always be person-centered, and they should also be culturally sensitive. They should meet the person's unique and ongoing needs. No two people are alike, so we have to individualize care. And regardless of the degree or the severity of Alzheimer's, care staff should always focus on the preferences, the wishes, the desires of the older adult. We need to keep their preferences in mind. Palliative care may be necessary at one point over medically aggressive care. Residents may still need to be treated, though, for infections, pneumonia, and heart failure. Palliative care doesn't mean pulling the plug on all medications and all treatments. It just means that the focus is going to be on comfort, quality of life, and preparing for quality of death, instead of treating diseases and disorders so aggressively. Care goals should include addressing and treating pain, reducing discomfort, and, in general, improving the quality of life for that adult. All of these will eventually shift in focus from quality of life to quality of death, equally as important. The decision-making process will involve the resident, as long as he or she can, the family, the physician, medical director, so on and so forth, as well as caregivers. An important care goal is to understand and implement the residents' wishes and their values, and try to honor them as much as you can. Decision-making will also involve perceptions of the residents' quality of life. Let me explain. We perceive as caregivers, if the residents' quality of life is good, then let's be more aggressive with treatment and medications and therapy. Why? We want to prolong that quality of living, right? On the other hand, though, if you sit back as a healthcare professional and you're looking at the older adult and you're saying to yourself, you know, they are just lacking in quality of life. Why should we continue to be so aggressive in our medication and treatments and therapy? And, you know, what are the potential outcomes at this point? So it's a balancing act. But if the outcomes are not so good for quality of life, then perhaps the resident, the family members, the legal guardian, the professional staff, they might say it's time for palliative care, depending on the level and the severity and the closeness of death perhaps, or it might be time for hospice. Goals of care will be influenced by factors such as the invasiveness of a treatment. Does it hurt? How long does it take? Does the treatment absolutely wipe the older adult out and zap them all of their energy so that they're unconscious, they're overly fatigued? What about advanced directives, the cultural context of the resident and his or her family? And of course, trust or distrust of the caregiving team. That's important. And gaining trust from residents and family members, the legal guardian, is, I think, one of the most critical things that you can achieve. One of the most important things is that trusting relationship. An important care goal is to discuss with the family end-of-life issues, possibilities, and decisions before a crisis emerges, and then people have to make decisions very quickly without a lot of thought and without a lot of communication. End-of-life care may eventually and periodically involve a transfer to the hospital. And perhaps you know, perhaps you don't, that Medicare and Medicaid frown upon frequent hospitalizations and re-hospitalizations within 30 days, 60 days, and 90 days. But sometimes the necessity is there, and the skilled facility simply cannot meet the needs of the resident, or they are not equipped to provide the level of medical care required by the resident. So transfer to the hospital is something that should be discussed early with the family, with residents, and whomever else might be a part of that decision-making process. Usually, in my experience, it has been the social worker or perhaps the director of nursing who is sitting down and talking about that. There are pros and cons to transferring the older adult or the senior to a hospital, and it can be considered appropriate only when care cannot be provided in place or at the skilled nursing facility. Cardiopulmonary resuscitation, or CPR for short. Now, regardless of what I say in this program, always check your facility's policies and procedures on CPR. But what I could tell you is that for residents who have severe dementia, CPR is generally unsuccessful and can actually be rather harmful as well as undignified. This is in no way a message saying do not perform CPR on individuals with severe dementia. What I need to stress again is check your policies and procedures in your building. If you don't know where they are, go to your director of nursing, director of social services, or the administrator. CPR attempts provided when the arrest is not witnessed. Okay? The resident might have a cardiac event in their room by themselves. No one saw it. This type might have an extremely low chance of success. And if it is successful, it carries a high risk of worsened function due to hypoxia, which is a lack of oxygen to body parts. And of course, all of that depends upon how long the resident was unconscious, how long were they on the floor or in their bed, and how long has it been since they had their cardiac event. Lots and lots of variables here. Other important care goals include symptom control and management, good mouth and oral care, regular pain assessment, comfort feeding, attention to dignity, frequent reassessments, and comfort measures like the use of therapeutic touch, music, movies, art, the Bible, prayer, meditation, all of those things, anything that is familiar to that resident. Now, what we really need is high-quality, person-centered care at the end of life. This is one of the most important care goals for advanced dementia near the end of life. Responding to the needs of the resident and family as they change is very important. Keeping the resident in place as long as possible and only transferring to a hospital when the need is critical and the care community cannot provide either the type or the level of care needed. Person-centered care at the end of life includes care with dignity, enhancing both the quality of life as well as the quality of death. Managing pain is essential. Also paying attention to spiritual and cultural aspects of care. Advanced care planning is an important goal and is essential in dementia care and end-of-life care. It involves the process of fulfilling the residents' wishes and their preferences concerning their care. Issues such as artificial nutrition should be discussed and implemented. It should also be made clear to the family that tube feeding is not associated with improved nutritional status, prevention of pressure injuries, or reduced infections. In other words, tube feeding may not increase survival rates among residents with severe dementia. Feeding residents small, bite-sized foods can be more effective in maintaining their nutrition. Giving small sips of fluids can be helpful too. Decisions will have to be made about the nature of the treatment, for instance, how invasive is it, and its long-term benefits to the resident. Will the interventions being provided cause discomfort or reduce pain? That's a good question. Another, if interventions have no tangible benefits, should they then be discontinued? Well, that takes us to our final learning objective. Thanks for hanging in there with me. We are almost done. Now I'm going to explain how palliative and hospice care can improve quality of life. Whether palliative or hospice care is involved, they should both be person-centered, which involves forming a genuine and caring relationship with the person receiving care. It's important to know the person in terms of their likes and their dislikes, preferences, gender and ethnic qualities, and of course, their interests. It is this knowledge that helps to improve quality of care. End-of-life care involves managing symptoms, improving quality of life, and eventually enhancing one's quality of dying. Supporting the family is important. End-of-life care will be physical, emotional, and sometimes tiring and stressful, but it always should be compassionate and genuine. It should involve open and ongoing honest communication from all parties involved in the resident's care. Comfort should be maximized. Pain should be assessed regularly and addressed immediately, because the resident may not be able to express their own pain. It might go unrecognized, and if it does, it goes untreated. It might stem from immobility and not moving around a lot. It might be the result of an infection or arthritis, as well as other comorbidities or co-occurring conditions. The resident with advanced dementia may express their pain through anger, frustration, yelling, and perhaps combativeness. On the other hand, they may withdraw altogether, not come out of their room, not talk a lot, not make eye contact. It is therefore important to monitor for nonverbal signs of pain, including grimacing, moaning, and uncharacteristic behaviors or physical changes like sweating or elevated heart rate. Those are two decent indicators of pain. Staff should assess any and all vocalizations or complaints of pain. Pain is easier to prevent if it is treated in an ongoing way, and it is difficult to relieve once it has begun. Try to connect with the resident through their senses. Continue to use therapeutic touch. Always speak calmly and with reassurance. Raise their head for them if they're experiencing breathing difficulties. Tell stories. Reminisce. Listen to music or watch movies together. Keep the lights low. Moisten their lips if they become dry or cracked. Focus on the resident's most pressing and immediate needs. In other words, what do they need right here and right now? Is it a physical need, an emotional problem, or is it something spiritual in nature? Use slow and gentle movements to reposition the resident for maximum comfort. Tell them many times that they are cared for, they are loved, and they're in very good hands. And now, my final thoughts on this topic. Most people with advanced dementia will die in skilled nursing facilities. Generally speaking, we're all going to die in a nursing home, in a hospital, at home, or in a plane, train, or automobile. So, the majority of us will be in a nursing home. Advanced Alzheimer's disease is truly a terminal illness. It does not get better. It does not reverse. There's no cure. And there's no medication to slow it down or to stop it. That sounds like a terminal illness to me. And it should be approached that way. When the resident can no longer make decisions, the family will become more and more important in making decisions. Families need to be educated, and well educated, on the types of care and services involved in palliative care as well as hospice. And that's a tough topic to approach. They need to be part of the decision making concerning comfort care, the use of medications, and towards the end, the withdrawal of nutrition and or hydration. None of this is going to be easy on anyone. It's not going to be easy for the family to discuss these things, for the resident, or for the staff. Although it is difficult for clinicians to determine when end of life will take place, there are a number of signs and symptoms that need to be closely monitored because the needs of that resident are going to change. Goals of care should be clear and agreed upon. They will change as the disease progresses. Person-centered care is the only model of care to use. The decision to transfer the resident to the hospital must be made with all known facts. CPR is going to need to be addressed. Advanced care planning will also need to be addressed. Well, that's it. We've come to the end of the end-of-life care and Alzheimer's disease course. I would like to thank you for your time, and I just want to do one more thing before I go. Let's look at the learning objectives and just make sure I did a good job on each one of them. Number 1, I reviewed physical and cognitive issues at each stage of Alzheimer's disease. Number 2, I listed care goals for end-of-life care. And last, number 3, I explained how palliative and hospice care can improve quality of life. That's it for me. I'm Dr. Jim Collins. Be well and take wonderful care of the older adults and seniors in your facility.